Hi, my name is Megan. I work very closely with Roger, and we have filmed this conversation between the two of us to help you get a little bit more of a feel as to how we work together and how we both contribute to patient management. Hope you find it useful. Hi, Roger. It's nice to talk to you this afternoon. I'm really pleased to talk to you because I've got a patient question that I want to ask you. But before we get that, let's just introduce ourselves for anybody who's watching this who may not know us. My name's Megan and I am an endocrinologist.
Great. Thank you, Megan. And we also have already a bit of a working relationship.
Mm.
So my name is Roger, French pronunciation of Roger, and I'm the specialist doctor at the New Zealand Eating Disorders Clinic, trained in Germany in psychosomatic medicine, which is a sub area or separate area of psychiatry, and deal a lot with presentations where the physical body or also psychiatry and psychological aspects matter. And yes, I have worked a lot with eating disorders, but not only that.
And we've worked together for about 10 years now, right? And shared a
Yes,
lot of patients.
that's
So I
exactly true.
saw a young woman this week that I'd be really interested in your thoughts and opinions on. She's
Mm,
22 and she hasn't had a period for 2 years because, of course, that's why I typically see women because periods have stopped or changed. And she lost some weight along the way. And it's quite clear that the diagnosis is that she's not fueling enough. So she's in an
mm,
energy deficit. And that's why her periods have stopped, and her hormones support that, and her scan supports that. She went to see one of the sports dietitians that I use that knows so much in this area. And he typically gives his women that he has seen a large amount of information about how they should fuel to get into a positive energy balance. And it can feel quite overwhelming to start with because it
mm,
often is a big jump up in food from what they are used to eating. And she came back to see me and she said to me, I know that I need to do this. I know this is what will make me healthy, but I can't do it. I'm not doing it. And
mm,
I said to her, well, I think we need to find out where the block is and what's stopping you doing
mm,
this.
mm.
And I'm going to ask my colleagues. So I'd be really interested in your thoughts as to how you'd approach that.
Well, I guess the first point would be, I think it's really useful to already look at also what is getting in the way and having a very open mind about it, rather than looking at it just from a practical perspective and say you have to eat more. And it's quite true, there can be lots of factors there. And I would, of course, and it might also be something that I know that you are quite aware of. There might be other factors. Sometimes there's high levels of anxiety that make it difficult to eat. And I think we all have experienced that somehow the brain shuts actually down appetite or some mood factors. So that would probably be useful to kind of have some clarity on whether it's just something what's currently going on in a person's life. Um, I would want to explore more carefully what have has the person maybe tried and what was the experience of them not being able to do it. In other words, did they started to get physical symptoms when they started eating in terms of nausea? Then I would again explore, is there also a feeding quality there? I would also look at, is it maybe that part of them what makes it so important for them potentially to be at a lower weight? Does their sport require it to them? Are there some other factors? Is it hard for them, or do they find it actually quite important for certain reasons to maintain the diet? For sometimes there can be some, I would say, perceived health factors because there's a lot of misinformation floating around that are maybe associated. There could be some other dietary reasons. So there are lots of factors that need to be explored in order to understand better and for the person to also understand better. And sometimes that could potentially already be enough to kind of allow them to approach the eating more in a different kind of way and to just tweak what they have been doing. It might also be that they might need a little bit of support or coaching in terms of supporting them when maybe some identified factors have come up. Say it is anxiety, it might be useful for them to recognize it a bit earlier and then be able to find different ways of dealing with it. So some of it is quite practical. There is, of course, the third possibility. It could already be underneath it a true eating disorder going on, even though in my experience, that is not necessarily the majority of cases, but that would, of course, also be something that one would also, and I would also explore to kind of look at. So it's basically about getting a better understanding, and not jumping to kind of quick conclusions.
Mm, mm. Because I say to the girls, why don't you go and see Roger? He's at the New Zealand Eating Disorder Clinic. And I often get pushback and anxiety because people have perhaps said to that young woman, you've got an eating disorder, and she's got a
Mm.
lot of concern that walking in your door is going to give her that diagnosis.
Yeah, I mean, so I guess in a way, it's true we are an eating disorders clinic, and we also get a lot of referrals of people where, in some ways, the diagnosis has already been made, maybe by a GP or by a psychologist, and we provide that kind of high-end specialist treatment. So that's all true and correct, and I have a key role in that. And at the same time, particularly my role also in terms of my background is very much also to basically tease apart a little bit a presentation like whom you just described there. And so therefore it's also quite important when if they then in the first instance come, they see me for that specific, I often provide second opinions that review what is really going on. So there's quite a number, significant number of people that I see, they just come once.
Mm,
And yeah, and it's just about having a clear opinion, and then they can go with it, and then they have a bit more of a direction. And some, of course, also end up at intending to treatment, but certainly not everyone. So it's more about using me as a specialist who can provide more in-depth understanding of what is happening and to
mm.
inform what the next steps are if needed.
Because they get very frustrated with the statement that many of their friends and family have given them that says, just eat more. For goodness sake, I would love to be in your position and be able to eat more.
Yeah, I mean, in a way, we, this kind of what I would call stigma, and I must even have to almost hold my mouth there a little bit because in some way it's so uninformed and so unhelpful to make those kind of statements. I have heard it a lot in terms of, oh, I wish I had, and this kind of problem, which is unfortunately a reflection of the lack of understanding. So I guess the advantage is that I say now we, the clinicians working here, but then certainly also I have a quite a differentiated understanding. So it's really important that if someone does come to see me, or then potentially even someone in here, that we would actually come from that place of the person here with their specific kind of presentation. And maybe I can also add that an eating disorder, not eating is not necessarily an eating disorder, or not eating enough is not necessarily an eating disorder. Also, people can have an eating disorder and look and be at a totally normal weight. So nobody can see that from the outside. And
Mm,
lastly, also, those individuals who end up having an eating disorder, and it's really important and not so well understood, it's basically, quote, an unfortunate few who have a number of genetically determined vulnerabilities for whom, when they start engaging in dieting or exercising more or some kind of weight loss for whatever reason, these genes get switched on. And
mm,
when I explore that with them, they can really describe something changed, even if they had once wanted to start on a diet. And then something changed, and they feel all of a sudden really taken over by that. And that's
mm.
only a small minority, but it's important to also recognize those in order to help these people protect themselves and actually get out of it again, and then to be able to prevent it from kind of becoming reactivated. So I think the comparison to vulnerability to, say, melanoma is probably quite similar.
Because often there's a genetic family history, right?
Well, that's when it's most obvious, but not necessarily because it's not just one gene or so. So in a way, it's a combination of genes, and there's probably also a certain degree of vulnerability. So in other words, someone has a very high risk, or say with maybe an area that you would be more familiar with, and there's also breast cancer. Yeah, so there are some cancers where a certain kind of combination of factors, to some extent also hormonal ones, if they all come together, the risk is really high. And then some sits more in the middle and some is really low. It's not that different with eating disorders. There's lots of different genes, metabolic ones as well. I mean, I could go into it, hormonal ones, leptin. So there's many factors that kind of, if put together, it's a little bit bad luck or good luck with what kind of combination we end up. In some cases, yes, there's other people with eating disorders in the family, and then we know usually the risk is actually very high, but it's not necessarily the case.
Mm. So a person comes to see you and they have an appointment. What's
Hmm.
the possible outcomes of that?
Yeah, so I guess it would be, I would usually say it's a 60-minute review. So where I kind of also use the information, say if it was someone that would come referred by you, there would already be some information there. So I would explore some of the areas that I'm aware of could potentially be contributing, understand, look also what more, what their experience is. And the outcomes could be manifold. Yeah, so one would be to kind of clear identification of something very minor and say, okay, maybe try that. It could also be that, yes, almost some clarity about us, more about anxiety. There might be then some suggestions of what kind of intervention it would be. It could even be maybe having a few coaching treatment sessions here within our clinic by one of our clinicians that targeted some of those kind of factors. And yes, it could also be if it's very truly, this really looks like an early eating disorder, we would then talk about what kind of options there are and the importance of, or not how soon to really engage in treatment. So the outcome could be quite manifold, but it's basically ultimately you end up with a letter, a reasonably detailed letter, that is also fully discussed and usually kind of puts out treatment options.
Mm. I think it's important, right? Because in my experience, having seen a lot of women go through different versions of this journey, for those that really have an eating disorder, the quicker that we make that diagnosis and the quicker we get therapy instituted, I see them do so much better.
This is so true. I mean, in a way, that's probably one of the, I mean, I often say with eating disorders, it's a race against time. Yeah, we
Mm.
know that the shorter the illness duration, the better the chance. And I mean, we both know that from basically, and it's even common sense with many medical presentations, it's exactly the same. Catch it early, short and sharp intervention, and out. So it's super important. So what we really want to say, like, oh, take the threshold down, and and we also understand if it is kind of really hard to kind of want to the idea of making some changes, and if that was very scary, it usually means there is probably something more major going on. And I guess what I can definitely say with a lot of confidence, we would be exploring that in a very supportive way because forcing someone to do something just ends up with the opposite. Yeah, and we know it's ambivalence and change is kind of a little bit scary. So we would the treatment always takes that into account. So if that was the case in those very few cases, but yes, then we would want to be there as quickly as possible. And yes, we could provide that because that's what we do.
Because otherwise, right, you see, it tends to be women. There are some men, but it tends to be women.
Mm.
And you see women just lose years of their life to this battle of untreated eating disorder. And I think that's so sad because typically they have so much potential to go and do
Mm.
all sorts of other things.
Megan, I mean, in a way, I, you couldn't be more right. And I guess we actually see quite a number of cases because we're kind of a little bit more that high-end kind of clinic, specialist clinic, where you can see, oh, and often they say themselves, oh, I wished I had had
Mm.
this kind of treatment early on, because often they would have had half-hearted treatment, not really done well. It's almost like antibiotics stopped after day two and not really gone all the way if needed. So, and I guess
Great
you
metaphor.
yes, and also you would probably particularly you space see quite a few women who kind of just carry on and then they have protracted time of not a period. But it's also not just not the period. It's also about all that kind of thinking about, oh, what am I having? What can I eat? How much do I eat? What is my weight? How much it takes away from having the kind of chance to actually explore their life more fully and really take advantage. Because usually these are people who have lots of potential, they're often quite driven and kind of detail focused. All of these are qualities that actually can be very useful in life. But if they get taken over, if it is an eating disorder, it all gets kind of funneled into this kind of entirely destructive kind of area.
Mm.
So,
Often I ask women how much of their day do they spend
mm,
thinking
mhm.
about what they're going to eat, have they done their exercise, their anxiety over not doing their exercise, what happens if those food choices
Great
are not
questions, yeah.
available. And it is a significant component of their day. Imagine what they could achieve if they had that
Mm.
headspace available for something else.
Yeah, so if someone responds that back to you, that already kind of indicates there's what we call quite already some impairment. So it has an effect on their ability to function fully, and they really can't get out, and that somehow they're often so in it that they haven't even thought about how much time they spent about just thinking about food and what they avoid because I don't want to eat because there could be some food, or I can't go to the place because I don't know what's on the menu. But that already, I must say, often would kind of raise the suspicion, this could be more than just a little bit of general anxiety and I don't have any appetite. Yeah, so that already has more of a feeling of eating disorder.
Mm.
And again, attending to it early, we see that all the time. And sometimes we have treatment just 10, 12 sessions and it's all done.
Mm. Mm. Okay. Fantastic. Thank you so much. I will send the
Thank you.
referral through and I will look forward to getting your thoughts back.
Thank you, Megan. It was a real pleasure to have that kind of exchange. Thank
Okay.
you. Okay.